All right, our first case presentation is a 54-year-old female who presented with a few years of right knee pain, most predominantly recurrent swelling after exercise. She had no history of prior trauma. She was seen at an outside clinic where she was being treated for arthritis based on her radiographs, and they actually obtained an MRI which showed some hypertrophic synovium, for which she was referred to Duke. On exam, she had a moderate knee effusion. She had a 4 by 3 centimeter mass in the lateral suprapatellar pouch, and she had a painful arc of motion from 10 to 90 degrees. Her x-rays showed advanced tricompartmental arthritis and lucencies within the medial femoral condyle and tibial plateau. Her T1 MRI shows hypertrophic synovium as well as substantial subchondral cysts and erosive changes of the femur and the tibia. Her imaging and history were concerning for pigmented villonodular synovitis. She went to the operating room on February 12th for a right total knee arthroplasty with synovectomy. When the knee was opened, it was filled with brown frond-like material. A specimen was sent for frozen section, revealed PVNS. A complete anterior synovectomy was completed. The subchondral cysts were curetted, and a total knee arthroplasty was performed. Her histology slides showed on the left the characteristic finger-like projections of PVNS as well as hemosiderin deposition, which is responsible for the brown pigment. The image on the right shows characteristic lipid-laden macrophages and multinucleated giant cells. The patient went home on hospital day 3, and at her 2-week visit was doing well with a arc of motion from 5 to 75 degrees. We'll be talking about PVNS. This is a proliferative condition of the synovium that's locally aggressive and progressively erosive. It's characterized by inflammation and hemosiderin deposition. The pathogenesis is unknown. When the disease was first being described, it was thought to be traumatic in origin, with local hemorrhage causing the hemosiderin deposits. Although more recently, it's thought to be either neoplastic or inflammatory. Recent cytogenic analysis has actually showed a translocation of the CSF1, or colony stimulating factor 1 gene, which is on chromosome 1. It's actually a spectrum of disease. There's a local form which generally consists of pedunculated or lobular lesions, typically located in just one aspect of the joint, which typically in the knee is the anterior knee. Marginal excision is usually effective with a low recurrence rate for local disease. For diffuse disease, it involves the entire joint synovium. It might also include extra-articular extension. This is much more common, more destructive, and has a higher recurrence rate than the local form. When it is present extra-articularly, it's known as pigmented villonodular synovitis of the tendon sheath, or more commonly giant cell tumor of the tendon sheath. These typically present in a monoarticular fashion, with the knee being the most common joint. Other large joints are also able to be involved in this process, though, too. The typical symptoms are pain, intermittent swelling, and effusion. One of the hallmarks is recurrent atraumatic hemarthrosis. Typically in diffuse disease, it follows a slow and insidious course. In local disease, mechanical symptoms can be involved, like locking, catching, or instability. It's a relatively rare process with an incidence of 1.8 per million. The typical age of presentation is somewhere in the 30s to 50s. Up to 70% of patients have no changes on X-ray. However, when they are present, they can include periarticular erosions with a thin rim of reactive bone, nonspecific soft tissue mass, and late changes can actually also be indistinguishable from osteoarthritis. MRI is the most effective screening modality. It can show synovial thickening or a mass with varying degrees of bone erosion. The hemosiderin deposits in the lesion lead to a low signal on T1 and T2. So it's commonly described as dark on dark. Gross specimens can have a fibroadipose appearance and nodularity, as well as a brownish discoloration from the hemosiderin deposition. The image on the right also shows villonodular protrusions, again with some brown discoloration from the hemosiderin. Histology classically shows highly vascular villonodular projections, as seen in the top image, along with multinucleated giant cells. The bottom image, the blue arrow, shows some of our lipid-laden macrophages, as well as the brown pigment of the hemosiderin deposition. So the primary goals of management are to remove all abnormal synovial tissue in order to remove the source of pain, as well as lower the risk of joint destruction and avoid recurrence. There's really not much of a role for non-operative management once a patient becomes symptomatic. Surgical options include marginal excision via arthroscopic synovectomy. If it's a local disease and can be taken out arthroscopically. This typically has a low recurrence rate and can be usually pretty effective. For diffuse disease, the arthroscopic approach might require posterior portals, a 70-degree scope, greater surgical expertise. So often a combined arthroscopic and open, or just a complete open procedure is required to remove all of the synovium. This, of course, carries a higher risk of complications, including postoperative stiffness or a risk of damaging neurovascular structures in the back of the knee. If severe degenerative changes are present, then arthroplasty is usually also performed at the same time. Other forms of treatment include radiation, external beam radiation, and intra-articular radiosynovectomy. These have been performed for decades, either as a primary form of treatment or adjuvant form of treatment. They have kind of mixed results and a lot of complications, skin changes, stiffness, poor wound healing. It's worth mentioning one of the newer therapies, which is this PLX 3397. This is currently in a clinical trial at Duke. This is a small molecule receptor tyrosine kinase inhibitor. It inhibits the CSF1 receptor. This is that colony stimulating factor 1, which causes proliferation of tumor-associated macrophages and osteoclasts, typically associated with PVNS. Two quick systematic reviews. The first one here is from a group in Paris, published in Arthroscopy in 2014. They were looking at arthroscopic versus open synovectomies for both local and diffuse disease. They noted that there's no difference in recurrence or complications for arthroscopic versus open for the local disease. They noted for diffuse disease, there's no difference in recurrence, about 16 to 22% arthroscopic versus open, but a much larger difference in the number of complications, 20% versus about 0% for open versus arthroscopic. Again, some of this is probably due to selection bias because the more diffuse disease will typically be treated open. So there's probably a slightly higher chance of recurrence there and a higher chance of complications. They did note that adjuvant radiation seemed to decrease the rate of recurrence for this diffuse disease. And then just another review actually looking at PVNS of the hip. This was out of Rush just last year, looking at synovectomy alone versus synovectomy with arthroplasty. They noted no difference in revision rate. It was about 25%, but there was a longer time to revision for patients that were having arthroplasty at the same time as the synovectomy, 11.8 years versus 6.5 years. So quickly in summary, this is PVNS is a proliferative lesion of the synovium with inflammation and hemosiderin deposition. It's a spectrum of disease which includes diffuse, most commonly, and local forms of the disease. There also can be extra-articular extension. MRIs are our most helpful diagnostic tool. If it's local disease, it can generally be taken out with an arthroscopic synovectomy. If it's more diffuse, then thought needs to go into either a combined approach or a larger open synovectomy. Arthroplasty can be performed at that time if the patient also has end-stage arthritis. And if it's recurrent or very diffuse, then radiation can also be considered. And as we're starting to understand a little bit more about the pathogenesis, there might potentially be new roles for medical therapy. Right at the 10-minute mark, so I'll skip the YTE question. I'd like to thank our tumor team. These are the references, and this will open it up to our experts.
So that's a really nice review of the topic. Were you guys Brian and Will, you guys said something or will we start some questions?
No, we're happy to start.
Go ahead.
I was going to mention one of the interesting things about PVNS is that you think of most tumors in general, and when you take out the tumor, most of what you've got is tumor. When you look at PVNS, the cells that are translocation positive and the cells that are actually neoplastic, if you believe it's neoplasm, are less than 10% of this whole tumor. The majority of the cells are mononuclear cells. So I think this new drug is very interesting. It is a small molecule drug that hits multiple tyrosine kinase pathways. It also hits KIT, and I think its role in suppressing CSF1 is probably has a lot of potential. I have a question for the sports guys. How confident do you guys feel that you can do a total synovectomy arthroscopically? I was surprised by that French paper that the data was so equivalent.
So, go ahead. I think there's a couple things. How confident do I feel? If it's intra-articular, I feel pretty confident, but I also feel confident because I have used a lot of posterior lateral and posterior medial portals. For the average arthroscopist, they're not used to using it. So if you have posterior disease, it's intra-articular, a lot of that's going to be missed. That said, if there is extra-articular extension, I think doing it all arthroscopically is not the right answer. That's been clear in my own experience. Those are the ones that have come out.
I agree with what Dean said. A lot of my cases had extra-articular infusion of the two fossa, sometimes in the quadriceps muscle approximately. So I often combine the arthroscopic dissections. I think the synovectomy is better arthroscopically, no matter what anybody says. I think with all the portals you can resect most of the tissue. And then basically do an open incision posteriorly and do an open excision of the extra-articular portion. So I think in a young person, I still think it would benefit to do an arthroscopic synovectomy versus a open synovectomy. And we know the investigator from Paris, Willie Hardy. I think he's a pretty good investigator. And the French society, I think, is pretty good in terms of accumulating their cases and reporting their cases. There might have been some bias in terms of the severity of cases, but I think it's significant.
Yeah, I think Matt pointed that out. This was not a randomized controlled trial. So you're going to have bias in terms of patient selection. It's going to bias the results towards more complications and more recurrences. Don't because those are the ones that are going to have more complications. So, Matt, I think you did a great job of really summarizing this, figuring out the most important ones.
It's important to notice, as you mentioned, Matt, this is a huge spectrum of disease, and some of these things, like a local nodular site is a tooth or puncture. It doesn't matter what you do; those are going to be really low. On the other hand, there are folks who have disease in the hand or in the foot, for example, where you'll see disease all through the carpus or all through the midfoot or hind hand. And those folks are going to be poorly no matter what you do. And I think those are the folks who are going to benefit from potential medical therapies. It's not going to be folks with a single nodular elbow or their knees. There are cases where you cannot do the surgery with the scope oral.
Okay. I have a question. I think this is a really curious lesion. I think what Will said is right. There's probably a small number of abnormal pathologic cells that make something that make this bad reaction around it, which is why it's kind of hard to treat. I'm just curious though, the patients who had an arthroplasty as their treatment, not arthroplasty secondarily, but you did the simultaneously arthroplasty and the synovitis at the same time, right? In those patients, does it recur? So if we take out the articular surfaces, does the thing recur or not? Because if you do a synovectomy in other places, there would be a slight recurrence rate. Do you know what I know it's a really small series, only 100 patients, not very many. Were there any recurrences of PBS?
There was one paper, so that's one of the problems with all these series or annotations, situations that are combined. But there was one from JBJS in the late 90s, and I think there were 11 patients. There were 4 recurrences. So
That may be right. I don't know the only arthroplasty people we signed it in that. I just wondered whether or not people want to see who follow arthroplastics. If they could say, I was a little bit concerned about doing the synovectomy and the arthroplasty all in one go.
What are you concerned about?
Well, because of that, because you make sure you really don't synovium.
So, what's the pathology of PBNS that causes arthritis?
Yeah.
So I expect this lady's PBNS to recur, but I don't expect her to cause arthritis in her.
But it might cause leucine prosthesis.
It could.
So that's the thing we surveil for is leucinating prosthesis. But I mean, we see that a lot. That you've replaced a joint and PBNS recurs near the joint.
That doesn't make a difference.
Is there a role for you getting there, you're doing your synovitis, you realize it's just extraordinary disease, and is there a role then for external beam irradiation post-operatively?
There is. It depends where you are. Here, the radiation oncologists are pretty conservative. It's really, really reluctant to give radiation.
Remember, radiation has its own set of complications, and those folks are going to get a stiff knee, and they're going to have a risk of cancer now in their knee. So we try to avoid radiation, but there is a role.
Yeah.
I just had a question on the case that was presented. Did you patellar resurfacing?
I believe it is.
Yeah.
It didn't look like it was. There's still some system in the patella. I was just wondering. I'm not an arthroplasty surgeon. I guess I can tell. But obviously, I thought that was once you remove all the articular cartilage and the synovitis, the chance of recurrence.
We were asking about whether or not it's about the safety of doing PBNS, taking the synovectomy and also the arthroplasty at the same time. Whether or not there was a higher
That's right. By the time they get to me, that's what they're there for. I think they often have some visual synovitis to get what I can see.
Do you see a higher loosening rate?
I think there may be some literature for that in older literature. I think with modern implants, I haven't seen that. I'm concerned with that.
The same is more like treating a tumor. When you take a tumor, we put a prosthesis by the same sort of thing we do, but take all the abnormal tissue out of the pipe as well. Yeah. Good job.